So on this slide, it shows you what we're trying to do for the our strategies. It is basically going to incentivize medical homes to manage total cost of care and get gain sharing, some of which the gain sharing can be quite considerable. There'll be no downside risk as you make this transition. So what you're doing now is your baseline, and anything you can do to improve that will instead to become a gain for your practice unless you're already very efficient and effective. We will, of course, expect some demonstration that you are meeting some quality metrics. So to achieve gain sharing and to achieve the bonus payments, we're going to be looking for some specific performance on nationally recognized performance metrics that show that you are doing certain things appropriately in primary care, preventive care, and chronic disease management. But in addition to the gain sharing opportunity, we're going to be offering new supports for practice. We're going to be offering supports for care transition to help you move your practice from the current environment, which is responding to the current fee-for-service system, to one that is more supportive of the goals of a true medical home environment. In addition, we're going to be offering you support for care management so you can help support patients between visits who may need some coaching or some support so that they can sustain the plan of care you've designed for them in the office in their home environments. And then finally, we're going to be giving you report cards and information that will let you know how you're doing, how you're improving, and how you are performing compared to your peers. All of this, of course, means we need to have leadership by you. And that kind of leadership means how you will then guide your team in your office and your colleagues to re-envision the way primary care should be and how you wanted it to be in your office, and how perhaps the current payment system has thwarted you in achieving that vision. So we think this is a great opportunity for everyone to reassess why they want to do primary care, how they are doing it, and perhaps shift the goals of what their practice is setting out to accomplish. Let's go to the next slide. So to talk about how you would potentially gain share with this, on slide number 1, it just shows that you have a baseline of performance in year 1, and if you can improve your total cost of care, risk adjusted, to beat trend or to reduce your total cost of care, you would potentially be gaining gain sharing in this activity. Now, on group number 2, it would be comparing you also to statewide activities. So if you're already one of the very efficient and very effective care managers out there, and there are a few that are doing it better than others, you would be able to obtain gain sharing immediately because you've already achieved a very high level of total disease management, total cost management in the framework of achieving the goals and metrics of a highly effective primary care medical home. So again, we're going to be doing this for the cost with a risk adjustment, and we'll be eliminating some very high cost cases that we probably would not hold you accountable for, an odd cancer here and there, or a disease that requires, say, very expensive medications that risk adjusted would still be quite a bit of a burden to your total cost of care management. So again, no downside risk, only the opportunity to restructure your care management approach to reduce total cost of care and to achieve greater chronic disease management. Next slide. What we're going to be doing is, unfortunately, we cannot expect to do this for each individual practice. And we're hoping that we'll have other payers join us as well. I know that some of the commercial payers are actively planning something to get involved in this area. But unfortunately, if doing this for a practice of 100 patients, the numbers really wouldn't work out to do appropriate risk adjustment and to avoid random case activities. We will be expecting folks to have at least 5,000 patients in their practice environment pooled together in order to achieve appropriate risk sharing for gains sharing in this program. Well, 5,000 seems like an awful lot of patients. Some of you are in big integrated practices. Some of you have multiple physicians in your group practice. Some of you have natural partners in your community or in other parts of the state. That would all be potential for developing collaborations and to pool your practice together and share notes on how to achieve total cost of management for this pool of patients. On the other hand, to go out and try to recruit colleagues to meet the 5,000 number could seem like a very daunting task. So we are offering to create a default pool where if you didn't want to go through this in the beginning and you wanted to just begin to get your toes wet, if you will, by doing so within the confines of the tried and true, you can opt to do nothing and to be part of the general pool of everyone in the state who volunteers for the program, just like we have right now with the Medicare CPCI program. All 70 practices in that program are in a common pool to share a common bonus if the group performs well on quality metrics and cost management. So just like in the CPC, all 70 practices would have to perform well to achieve gain sharing. Here we'd have a default pool where if you don't team up with others to meet the 5,000, you'd be in this great big pool, and if the pool does well, you would get a gain sharing opportunity. On the other hand, you can opt out of the default. You can identify partners, or you could be part of a practice that has a large number of Medicaid patients in your panel and go out and begin to organize your practice to achieve the goals of the medical home and total cost management. Let's go to the next slide and look at how, when you put your practice together, how we are going to support your practice to achieve the goals of the medical home and the total cost management as well as the performance measures. In the middle of the slide is a dark spot. That dot says we have 2 RFQs. We are looking for vendors to come in to be of assistance to practices should they want to have that support. There are 2 types of vendors. One is at the bottom there. We call it the practice transformation, and that would be folks who could come in to help you be coached to make small changes or make big changes in your practice environment to shift from high volume acute care management to more chronic disease orientation, to build up your medical team, if you will, in your office, to rethink how you use your office personnel to do more care management. The upper half of that slide, above the dark blue spot, we are going to have the PMPM's extra dollars to give you care coordination support. So you could actually have, either in your office or through a vendor, people who could reach out to patients who need, your high-risk patients who need additional support for coaching between visits to achieve adherence to referral requests, follow-up visits, medication plans, or just to make sure they understand that their home environment, their community environment, is appropriate to sustain their chronic care needs. So again, more holistic approach, chronic disease management on the top, practice transformation on the bottom. All of these supports and vendors are optional to you, but these are opportunities for you to refigure your practice and re-envision how you want to manage your day-to-day activities. Next slide. We have before us 2 contracts. The care coordination piece is on risk adjusted on average $4 per member per month. Some patients will get more if they're very complex. Some would get less, but would average out to about $4 per member per month. And that would be something that you could use either in your practice environment, within your colleagues that have supports, or through the vendor to achieve care coordination. On the right-hand side is $1 per member per month to have coaching in your practice for practice transformation. It is a flat amount. It is not risk adjusted. It is something that if you do not use a vendor, you would not get the dollar per member per month, so it has to be through a vendor. But again, it's an opportunity for more resources to manage your practice. So you could see if you have 2,000 patients on your panel, Medicaid patients, that'd be a large number, you would get an extra $120,000 a year to do care transformation and care management. If you had 1,000 Medicaid patients on your panel, and some of that's done in our system now by just one doctor. Obviously, if you have several doctors in your practice, that's not that uncommon. That would be an extra $60,000 per year for your practice to achieve care management and practice transformation. That's pretty serious support by Medicaid to the primary care medical home transformation approach. And we hope that this would become a welcome opportunity for you to, again, re-envision how you want to do primary care in your office and in your community. So, again, I think a great opportunity in that regard. Next slide. We believe that your clinical leadership or leadership in your practices will be important to achieve success. That would mean to rethink what is primary care all about. What is your thoughts about how you want to be an effective primary care physician? How do you want to achieve transformation over the next 6 months, over the next year, over the next 5 years? We don't expect this to be something that will happen overnight. I think all of us in primary care believe that we always are thinking about how we can do things better, how we can meet the needs of our patients more effectively. And clearly, this will be a learning process. And so as you go through these activities and try new approaches, you will find some things will knock off low-hanging fruit that will result in substantial efficiencies and effectiveness in your practice. Others will be things you will learn as you go ahead about how to potentially reschedule folks, how to use phone and email more effectively, how to use coaching to more effectively manage patients with literacy issues or frailties that might be able to avoid ER and hospitalizations by a little more attention between office visits. Obviously, this would mean potentially less acute care visits. You might find that you could manage more colds and ankle sprains by phone, for example, and then free up time in your office for chronic disease management, all of which would pay off in terms of total cost management down the road and potentially very large bonuses by better disease management by virtue of lower total cost of care. So again, we've had an advisory group helping us with this. We are going to be doing town halls. We are hoping to be hearing from you and your support staffs and your business managers about how we can make this something that is doable, something that is a challenge and a welcome opportunity to take advantage of a new way of paying for primary care. But again, it may mean reinvigorating your staff, engaging your team, and rethinking your daily activities.